Good morning. It is right at 9 o'clock, and we're going to go ahead and kick off the third annual Northwest Arkansas Health Summit. We are so excited that you all chose to be here today, and we are looking forward to learning a lot of really important information on how we can work together to improve maternal health, not only in Northwest Arkansas, but across the state. We have several great breakout sessions today, and we are going to have women joining us at lunchtime to share our stories, our strengths, as they highlight their birthing stories. And we will have Ashley Bearden Campbell here to moderate the panel with these women. This morning, we're going to kick off the day with Pearl Mcelfish. Dr. Pearl Mcelfish serves as the founding director for the Institute for Community Health Innovation at the University of Arkansas for Medical Sciences. Dr. Mcelfish holds a PhD in public policy, a master's degree in business administration, and a master's degree in community and economic development. She is a certified project management professional and a certified community developer. Dr. Mcelfish is a national and international leader in rural health and health equity, research and methodological research related to the best methods for conducting community-based participatory research and disseminating research results to participants and communities. In addition to her research, Dr. Mcelfish has led large inter- and intra-institutional efforts to develop academic programs, graduate medical education, clinical programs, population health efforts. Dr. Mcelfish has a history of funding from the Centers for Disease Control and Prevention, the Patient-Centered Outcomes Research Institute, and the National Institutes of Health. She has been awarded more than $180 million in federal, state, and private foundation grants, and she has published more than 260 peer-reviewed articles. Dr. Mcelfish is not only my boss, but a great mentor, and we're very excited to have her here today.
Thank you, Krista, and thank you, everyone, for being here. That was a long bio, so I'm standing there thinking I should have made sure there was a shorter bio, but thank you very, very much. It is so exciting to look out and see everyone here today. Many of you are friends. Some of you I have met for the first time. And I'm excited to see everyone come together with a commitment to really changing maternal and infant health outcomes in Arkansas. As we go through today, I want you to contemplate two areas that I hope that we leave this conference with. The first area is action. We know that Arkansas has the highest maternal mortality rate. We know that infant mortality and infant outcomes are poor. But we also have experienced over the last 6 to 8 months a real upswelling of commitment to change those statistics, to change those things about Arkansas. And as we are here today, the focus on action and what we can do is really the theme of this conference, this gathering today. The second thing I encourage you to hold in your mind as we go through the day is collaboration. There are many things each of the individual organizations can do alone, but the exciting thing about this group of people is that we have healthcare providers, we have community-based organizations, we have many women with the lived experience of going through birth and maternal care in Arkansas. And it's a real opportunity for us to connect with the organizations and the people that we can collaborate with in order to make a change. So concisely, I think collaborative action. And how can we leave today with an even greater commitment to collaborative action? Krista noted, and I want to just encourage, because it's one of the things I'm most excited about during this conference. Over lunch, we will be having women from diverse backgrounds across Arkansas sharing their birth stories, talking about why maternal care is important and important to them. And with that note of action and with doing, it is my great pleasure this morning to introduce our first speaker and our first panelist. It is a privilege to announce that Heartland Forward has released a report called The Economic Case for Investing in Maternal Health. I'm really excited to hear about that. Heartland Forward is a think and do tank with an emphasis on the doing, an emphasis on information and reports that translate into tangible action. Heartland Forward is a nonprofit, nonpartisan organization that serves as a resource for the Heartland, so Arkansas, but also many states surrounding Arkansas, to really drive important changes across the Heartland. The report that they will discuss today focuses on the states of Arkansas, Louisiana, Mississippi, and Ohio. The research is incredible. Even more incredible is that it comes with recommendations and a tangible action plan that we can all be involved in facilitating. Please join me in welcoming Ross DeVol, President and CEO of Heartland Forward. Ross?
Well, thank you very much, Pearl, for that kind introduction. As Pearl mentioned, we're releasing the study this morning, The Economic Case for Investing in Maternal Health. This is a big topic. It's one that has not received the attention that is warranted, and we hope to change that. In the last few months, it has been receiving more attention, but we need to keep working on that. So this is not only a human tragedy, it is an economic burden as well. It affects the workforce of today and the workforce of tomorrow, and costs our economy enormous economic growth potential. And there are also correlated effects on infants. So in this study, we viewed the lens of geography as a way to isolate it. You can't cover all the topics of maternal health. So as Pearl mentioned, we looked at Arkansas, Mississippi, Louisiana, and Ohio. The first three states are among the worst in the nation in maternal and infant outcomes. Ohio is very close to the national average and can serve as a benchmark for what other Heartland states could aspire to achieve with strategic investments and changes in public policy. So maternal health reflects a whole series of complex personal decisions, as well as decisions out of the control of individuals in terms of provider locations, insurance coverage, the social and cultural norms. Our focus is on the profound impacts of caring for moms today and on the state's current and future workforce. Maternal health is an economic and workforce development issue. And so we estimate how various investments in maternal health can benefit today's workforce and future productivity, as well as the next generation of potential workers. And we analyze this through both a medical and a related non-medical lens to provide some estimates on those numbers. So among those are the cost disparities in what we term undesirable birth outcomes and trans-county travel. A lot of moms travel out of their county for care. And we include a demographic overlay in this analysis so that we can explore the profound social determinants of health that affect those outcomes of mothers and babies. And we interviewed a number of medical and health professionals in this study. So it's not just a quantitative study in terms of economics, it also looks at practitioners and what's happening on the ground. And I think the team did a great job of blending those two together. So let's get right into the heart of this. So there are higher non-medical costs associated with seeking care outside of a mother's county of residence. the opportunity costs of time traveling, transportation, lodging, and all those costs are basically out of their pocket. And this disproportionately affects low-income Black families, Hispanic, as well as American Indian and Alaskan Natives. Alternatively, these minority groups may choose to limit travel because the costs are prohibitive and may remain local to have their treatment done and not necessarily looking closely at the quality of care, and that can have a negative impact as well. So the annual non-medical costs, what I discussed just a moment ago, the births outside of mother's county of residence, and the cost of preterm and low birth weight births totaled $63 billion across the United States and almost $700 million in Arkansas alone in 2020. So there are racial discrepancies in terms of undesirable birth outcomes. Across the United States, Black mothers experience the highest rate of undesirable birth outcomes. In Louisiana and Mississippi, it's about 27 and 26% respectively. They experience those adverse outcomes. That's about 10 percentage points, for example, above white mothers. However, in Arkansas, it's not the Black family that bears the burden. They certainly do, but the highest adverse outcomes are found within the Native Hawaiian and other Pacific Islanders, essentially the Marshallese population, but beyond that. So that really makes Arkansas kind of a unique outlier in that respect. So it just brings into focus the need for complex treatment and providing for more maternal health care providers. And women from these low-income populations may lack basic knowledge of their own physiology, nutrition, and reproductive processes. And so low health literacy combined with behavioral risks, such as smoking, alcohol consumption, illicit drug use, as well as the pre-pregnancy body mass index, really compound all these complexities. And culturally insensitive interventions are necessary among these populations. This is a busy chart. Let me try and explain it to you. And there's a lot more quantitative research behind this, which Amir can share with you. But the research reveals that there is a strong inverse relationship between the maternal mortality risk and the number of prenatal care visits. So as illustrated in this chart, part of the concern around out-of-county childbirth is access to prenatal care leading up to a delivery. If a woman receives 10 or more prenatal visits during pregnancy, the risk falls from 1 in 3 mortality death risk to almost 1 in 5, a significant decline when you have 10 or more prenatal visits. Now, we're not inferring causality here because we haven't examined it in that sequence yet. But if you look at the data, I think it's fair to say there is causality present. So access and proximity to mortality or maternal health are critical elements in keeping a mother and baby healthy. Access to postpartum services and care, both physical and mental services, could materially change these outcomes. So looking at some of the underlying correlated factors of what might be affecting maternal mortality and child mortality as well. As I mentioned, mental health conditions listed by the CDC is the highest single one at almost 23%. And there was a poignant quote from all the interviews that were conducted by the team with Becca Alexander, who's a senior manager of statewide services and operations at the perinatal outreach and encouragement for moms in Ohio. And she stated this mental health challenge poignantly. She said, in mental health, the challenges go beyond postpartum depression. There is a lack of systemic mistrust and a lack of access equity. And it's that access equity that's a key factor behind this, because increasing mental health screenings for perinatal women is a first step towards improving the understanding of mental health conditions and ascertaining which services women should be provided. And so that is just a critical nature. Also, the underlying connections to chronic disease have not been examined thoroughly, associated with the social determinants of health. Among those factors are pre-pregnancy obesity levels, as well as metabolic syndrome that's connected to that. A bit of a busy map here, but the point is to look at the number of Medicaid accepting obstetrician gynecologists in the 4 states that we reviewed. There's expected to be a 5,000 full-time equivalent shortage in OBGYNs in the United States by 2030, and this particularly could affect Medicaid recipients. So low rates of Medicaid reimbursement for OBGYNs coupled with the higher risks associated with the Medicaid population means that smaller or rural providers are struggling to provide those critical services. And we interviewed many people in the health profession and occupations who said this was a major issue. So for example, most OBGYNs that accept Medicaid provide obstetrics but not gynecological services due to differences in reimbursement rates and in additional administrative burdens in those Medicaid populations. And this has significant implications for preventative care and effective contraceptive options available to those potential mothers. So this kind of gets into the meat of those undesirable birth outcomes. And there are just abnormal differences between the cost of a healthy birth as opposed to an undesirable outcome. The average medical cost of a healthy birth in the United States is around $6,400. So a reasonable figure in the vast healthcare landscape. However, these medical costs skyrocket to $238,000 per birth for an extreme preterm birth, but even low birth weights and preterm births have much higher costs associated with them, $114,000 and $74,000 respectively. So these incremental costs reflect the higher neonatal care as well as potential development challenges and chronic diseases that are associated with them. So let's get into a few more of the numbers. I'm an economist, so I get to share that with you. Maternal health has demonstrative impacts on the workforce, and it directly affects a woman's ability to participate in the labor force, either through employment, through business ownership, or contributing in other ways through volunteering, supporting their families, etc. Further, successful birth outcomes prepare the next generations to live fulfilling lives and be productive workers. The lost wages from the premature death of moms and infants are a large economic cost. The years of potential life are enormous because mothers are young and they are in their prime working period. So the lost potential human capital from maternal mortality in the United States overall was just over $9 billion annually. And in Arkansas, it was about $170 million in the year 2020. Now, the lost human capital potential among infants that pass away is even larger due to the entire loss of their lifetimes and what they could have contributed to the economy. We estimate that the lost potential growth in the U.S. economy was about $90 billion annually to losing those infants, and about $1 billion in the state of Arkansas. And while the value of an individual substantially exceeds the lost wages in the workplace, it gives us an ability to try and associate the economic linkages to the loss of life of both mother and child. When mothers and children do survive an adverse birth outcome, there are additional impacts restraining the ability of a woman to participate in the labor force. Mothers may be forced to experience absenteeism. There's an emergency that occurs. And even when they do show up for work, there's a condition that's called presenteeism. They may perform subpar through no responsibility of their own simply because of the conditions they're facing. And there are going to be higher associated disability claims. So those overall workforce-related costs, even when the mother doesn't experience a severe negative outcome, cost the U.S. economy about $1.3 billion and almost $14 million in Arkansas, respectively. So when you add up all these medical and related non-medical costs, the undesirable outcomes from pregnancy, such as the death of the mother, the infant, a preterm or low birth weight birth, is both a human and economic burden in the United States and across Arkansas. Arkansas ranks at or near the bottom in most of these categories, and based on our calculations, the direct medical and related non-medical expenses, in combination with the broader indirect economic costs, such as the human capital, reduced work hours, and the labor force, cost the U.S. economy about $165 billion annually. That's 0.8% of GDP. And in Arkansas, it costs the economy $1.8 billion annually, which is 1.3% of the economy. So there you get a sense that it's much more directly affecting the state of Arkansas in terms of lost economic growth. So in the context of the U.S., the persistence of preventable maternal and infant mortality represents not only a profound human tragedy, but it's also a substantial economic inefficiency. And our research suggests that a significant proportion of these negative outcomes today are preventable through existing cost-effective strategies, and underscores a missed opportunity and one that we need for systems improvement. By preventing just half of these adverse outcomes, we're not going to eliminate all of them. That's what we should strive for. The U.S. could save approximately $78 billion. That equates to about 0.4% of GDP. And specific to Arkansas, such preventative measures would translate into an annual economic savings of about almost $900 million, or 0.6% of GDP. So to put this in context, that's essentially could underwrite more than 11,000 scholarships for nursing students on an annual basis in the state, or it could fund the establishment of 2 new modern 500-bed hospitals each year. So those costs are huge. So this is meant to illustrate the dual benefit of these strategic health interventions, dramatically enhancing maternal as well as infant health, while simultaneously resulting in economic savings. So the team put together, through the interviews and looking at the data, a whole series of potential solutions to this. This shows 6 of those that are at the top of that list. So amongst them, it includes looking at the healthcare workforce and looking at community health workers and further investment in those areas, as well as other areas such as healthy habits and preventative care, mental health services. We have a huge inadequate number of mental health care providers, not only in the space of maternal health, but overall. Health literacy over the long term will help, and even in the short term, and innovative ways to help low-income families get access to transportation so that they can achieve or reach very specific services that might be outside of their county. And also looking at childcare and family leave practices. These are huge burdens on mothers, many of them low income, trying to work in low-wage jobs, and it has a very negative impact on their ability to help their families. So we put together an action plan. We'll discuss this in more detail on the panel in just a moment, but just let me just mention a few of them. The community health workers is an area that we hope to support in maternal health. Telehealth, we're doing a lot with connecting the Heartland and Arkansas and other states, and through the provision of telemedicine and telehealth in the maternal space is an area that we hope to invest in further. And the healthcare workforce shortages, we have a pilot program on nursing career pathways in Southeast Missouri that we look to scale up and hopefully make it applicable to Arkansas and other locations in the heartland. And reimbursement transparency. Yes, you can't have a discussion about healthcare without discussing reimbursement, because that is a major reason for why we have inadequate healthcare professionals in this space. So let me just conclude by saying that the U.S. ranks 11th and 12th for maternal and infant death rates, respectively, among the 15 nations that have a GDP above $1 trillion. And we rank 13th out of those 15 countries in preterm birth rates. This places the United States behind Brazil, Mexico, and even Russia. We must do more to invest to prevent the preventable and improve the dire performance in Arkansas and across the United States. And we appreciate the opportunity to share these findings with you today. There's much more analytical work in the study than I can possibly convey in this short overview. But with the panel discussion, we hope to provide more background with Dr. Ferretti and Dr. Rodriguez Acala. I appreciate your time and look forward to participating in the panel. Thank you, Pearl.
Thank you so much, Ross. That was really intriguing. And as you said, every life lost or born to preterm or low birth weight is a human tragedy. The ability to put the economic indicator on it, I think, is going to be critical to shifting policy and to fueling that action. So really appreciate the opportunity to get a very first look at this important report. We now want to move on to a conversation with the lead authors of that report. And so it is my pleasure to welcome those two authors. Maria is the Program Director for Health and Wellness of Heartland Forward. Her PhD is in Sustainable Development from the University of Missouri, and she has been the primary qualitative lead and policy lead on the report. So Maria, please join us. And then Amir. Amir is a health researcher with Heartland Forward. His PhD is in geography from the University of Wisconsin-Milwaukee, where he conducted research in precision epidemiology and population health. Amir, we are thrilled to have you join us. Let's give our panelists a round of applause and we will go into the conversation. Thank you so much. Amir, my first question is for you. You led the quantitative research for this project, and Ross showed us lots of charts that were very interesting and showed the magnitude of outcomes. In particular, there was a focus on low birth weight babies and preterm births. Why are those two factors so important?
First of all, thank you so much for the opportunity to be here and present our study. So the reason behind picking preterm births and low birth weight was twofold. On one hand, these two undesirable outcomes are more common than other undesirable outcomes when it comes to childbirth. And on the other hand, when looking at them from the economic standpoint, they are adding more expenses or medical expenses to households and families. That's why we highlighted these two undesirable outcomes extensively in our report.
Thank you so much. It was definitely fascinating. Maria, you led the qualitative component of the research, and in reading it, it really gave some life and context to the data. Can you talk more about what you learned from the qualitative interviews and why that's important to the report?
Yeah, sure. So we did about 34 interviews in the 4 states, and we interviewed all kinds of providers, doulas, midwives, OBGYNs, and then also some professionals like community health workers, also some mental health providers, and then some people at the state level that work with policy. I think that if I were to say the number one kind of thing that I learned from that is that we're still struggling to put together the new mindset that we need to have with how we are going to offer maternal health care in the US. And so if you have this handout, there's a little QR code there. You can go to the report at the very end, and there's a figure there that kind of is not new to all of you who understand maternal health care, but it shows what people were telling us in one, and also what Amir found and William found in the quantitative analysis on what is the kind of new mindset that we need to have in how are we going to provide maternal health care. And we need to have more midwives, doulas incorporated, other kinds of professionals that offer other kinds of supports, not just medical. And that is one way to get us out of this crisis, but also we need to start thinking about preventing the crisis from continuing.
Thank you so much. I will look forward to going and reading those in more detail. Amir, my next question is for you. I was astounded when I saw the graph regarding the inverse relationships between the number of healthcare visits and maternal mortality. There was just this drastic drop-off, which we often don't see when we do quantitative analysis. Can you talk more about that and why we might be seeing that? Because we might think that it costs more to go to the doctor more, or those women are sicker, and so we wouldn't see that, but was really astounded to see that.
Definitely, it was definitely one of the most interesting findings of our report to be able to show the impact of prenatal visits and how they can lead to lower cost for families in terms of medical cost, and also being able to detect and diagnose these undesirable outcomes early on. And through our study, we found out if we have up to 10 prenatal visits, then the likelihood of having adverse outcomes, undesirable outcomes, and also unfortunate case of maternal mortality decreases significantly. And the number that we provided is the national average. Definitely, we know that each community has its own characteristics, and we should treat this case by case. But on average, at the nation level, we found out that 10 prenatal visits can drastically reduce likelihood of maternal mortality.
And let me just add to what Amir said. This is why the trans-county travel is so critical, because you find in most rural areas where you don't have access to the services that are necessary and you need to travel for those prenatal visits, it negatively affects your ability to have those 10 visits, right? So you may only have 7 or 6, and that has huge consequences in terms of birth outcomes. And it's disproportionately in the Black community, Hispanic community that suffer from that, and other low-income families. So while I'm getting a little bit detailed here, but there are some women who come from high-income families that will travel outside of their county for specialized services because they may have a pre-existing condition. But overall, when you look at especially low-income population, there is an association between whether those services can be provided locally and how many prenatal visits they accomplish.
I want to add one more thing. Social determinants of health, the number one issue in our country today is transportation. So for low-income women, transportation, childcare comes after in the qualitative research. It's huge, and we have to seriously start thinking about new ways of transportation. I joke around that we built this country assuming that everybody has a car, and that everybody has the money for the gas, and that everybody has the money to repair it if you have a problem. And that is really not the reality. And it's come to a point where right now we really have a crisis in transportation.
Thank you so much. Adequate prenatal care now it's a complex calculation, but in general, 9 visits is considered adequate. And one of my takeaways is we really need to go back and look. It may be that adding an additional visit, having care a little bit earlier could really shift outcomes. Maria, I'm so glad you mentioned social determinants of health, and it really leads into my next question around the importance of community health workers, doulas, midwives, who both provide some level of addressing social determinants of health and prenatal care, depending on which one of those three it is. So I would love to hear you talk more about the importance of community health workers, doulas, and midwives.
Yeah, sure. I think it's first important to understand that we all need to do a better job in educating the public on what exactly do midwives do, doulas do, and where's the role of the OBGYN, because we're not advocating for less OBGYN. We do need more. But we can definitely separate the low-risk moms going into being treated for their perinatal care by midwives, for instance. We have amazing midwives. We don't have enough. We need to do more. And then doulas are an amazing support for emotional support, informational support that the moms need. And then thirdly, the community health workers also provide these connections to, say, the transportation I just mentioned, or someone just needs a new job or needs a new housing because they're having issues with their landlord. So all these things are very important, because if they happen while the woman is pregnant, they're just much more compounded, and we're adding to the health, we're impacting the health of that mom and that baby down the road if we're not taking care of those things.
Thank you so much. I am excited and just thrilled to hear all the discussion about community health workers, doulas, and midwives, and to see some of those changes beginning in our state and really across the heartland. I know you guys are leading some efforts regarding that, which we appreciate. Amir, insurance is also an influence and one of those social determinants. And so I'd love to hear you talk about payment method and insurance and how that affects both maternal and infant outcomes.
Sure. So we were curious to know if we are going to see a significant difference in terms of prevalence of undesirable outcomes across different methods of payments or insurance types, Medicaid, private insurance, etc. We saw a very slight difference amongst these different types of insurance between mothers. However, this rather insignificant difference can be indicative of how complex the maternal health is and how important underlying conditions and social determinants of health are, as coverage and insurance payment cannot explain much of complexity and variability that we're seeing in prevalence of different undesirable outcomes.
Yeah, so there's many confounding factors, and I think further investigation is warranted. Because I do believe with the proper data, we can see discernible differences in terms of insurance coverage. And there were some differences in the data, but my opinion is greater investigation would yield that there are more significant differences.
Thank you so much. And I appreciate the acknowledgement discussion that each of these factors are really interconnected, and it's not about just addressing one of them, it's how can we address all of them, and with the synergy of doing so. Maria, you touched just a bit on telemedicine. Ross talked about transversing counties in order to get access. With the advances in telemedicine, mobile prenatal care or mobile care, what do you think some of the opportunities and contemplations should be around telehealth and mobile care?
Yeah, so I think that first let me separate. So mobile units are at the very beginning, from what I saw in the interviews, of being tested. So they're not widely spread yet, but perhaps they provide a very good solution. Maybe not the solution, but it could be a solution to increasing access in particularly rural communities or other underserved areas. with respect to telemedicine, I think that it's important that we clarify also that it is not meant to substitute for in-person, it is meant to complement. And that distinction is very important for the patients, is what we found. The other thing is, telemedicine is not gonna take the role in everything. We first need the infrastructure, of course, that Heartland Forward is working on connecting the Heartland, one of the issues we do, but it's not enough to just have the infrastructure. You have to also be able to access it because if you can afford it. And then the last component that's very important is, can they adopt the technology in the right way that actually benefits them? And what we found is that for mental health services, actually accessing telemedicine from the home is very actually a plus for rural communities. And this is particularly because you have a lot of taboo around mental health issues. So it can be an amazing tool if we were to have the others already in place, the three, the infrastructure, the affordability, and the adoptability. And then for other kinds of, for like the OBGYNs or even doulas, community health workers, they can do follow-ups through telemedicine. So it's not like they're going, again, to replace the in-person, but they're going to complement, and primarily when we consider this transportation issue, and then also the fact that sometimes people need to miss work to go to an appointment. So we need to be very sensitive to that. And then lastly, access to specialists is huge. We can do more through telemedicine, and that doesn't mean necessarily from the home, but it would be from a clinic in a rural community that a doctor or another provider would be accessing that specialist, and then that provider can walk the patient with the treatment. Sometimes that can be done through that provider locally, but sometimes we will need more to follow up with that specialist.
Thank you so much. I know that there are challenges to overcome, but I think a lot of opportunity. Intrigued to hear you talk about the engagement of community health workers and doulas in that telemedicine process, because there's not a lot of data on that, and it may be a really interesting area for us to...
It was mentioned in the interviews by doulas and by community health workers, so...
Not surprising. Doulas and community health workers are often on the edge of innovation and finding those out-of-the-box solutions. So thank you so much.
And unfortunately, many times receiving significant pushback from the medical profession. We need to be more embracive of the benefits that can be bestowed. And most MDs, and I love the MDs that are in the audience, but they're not necessarily on board yet.
Yeah, I think I've been seeing a shift in that in the last few months and years. And so I hope with education and conversation, we can continue to see that shift and really embrace the benefits across the healthcare provider continuum. Amir, I was excited to hear Ross present the non-medical costs, because we often look at medical costs, but we forget about all the other things, taking off work, gas, the other things that it costs someone to engage in healthcare. Can you talk more about that?
Sure. So just to reiterate, we are seeing that 30% of all childbirths in the United States are geographically discordant or in another county other than residence of mothers. So mothers, in 30% of mothers have to travel to another county to receive the care they need and also for their childbirth, which can put a very strong economic impact on their livelihood. On one hand, we have opportunity costs. They could spend the time that they have to spend on travel, on jobs, and also the mileage. And traveling alone and traveling to another county and the whole scope of trans-county childbirth indicates the scope of accessibility, affordability, and adaptability of resources, and how significant these issues of accessibility to resources for maternal care is in the United States, specifically when we are seeing a huge divide between rural and urban areas that significant percentage of mothers in rural areas have to travel to another county to receive the care they need.
And when you look at expectant mothers that have to travel more than 100 miles in many of these rural communities, the number of prenatal visits goes down way below 10, and they are interrelated. And so, as Maria was pointing out, telemedicine could help fill some of that void. And it's not just in the home, it also could be at the local clinic where you have better connectivity. So that's really important, I think, in terms of increasing the conversations and discussions earlier in the pregnancy and throughout.
And I want to add that for any woman that needs to go to an appointment that doesn't have a car and already has children at the home, you have to, it's an enormous job to just get that visit taken care of. So scheduling your transportation, if you're able to navigate the system, getting it paid, finding childcare. Many of the Medicaid transportation does not offer child seats. So there's lots of issues that just go behind the scenes that we underestimate, and we just, if you're not living it day to day, you just don't understand.
I was surprised and pleased to see transportation pulled out, not just lumped under social determinants of health, because in our day-to-day work that I know the team does, that's what we see and hear. We've had women walking barefoot to a mobile prenatal care visit because the extreme challenge with transportation is such a major issue. Thank you to the report, to Heartland Forward for pulling that out. In our last, we have about 10 minutes left, and I'd like to cover two things. The action plan was one of the most exciting things about this report. So from each of you, I would like to hear your thoughts on the action plan and what you think is most important that the state address first. And then as we have time, we'll open it up to a couple of questions from the audience as well. And so audience members, please prepare to do that if you would like. So in whichever order you would like, what are your thoughts on the action plan and what's most important that we should be contemplating as a state and a region of the Heartland?
I'll take first crack at it. I mentioned it. It's reimbursement rates and transparency, OBGYNs, not that many. We looked at the county level data in the 4 states that we examined, and you can clearly see the number of Medicaid accepting OBGYNs affects the ability of expectant mothers to be able to have those prenatal visits. So it's a disincentive to be in the Medicaid system. That's a policy change that we could change today if we had, I won't say the word I was thinking, if we had the fortitude, the intestinal fortitude to do so. People know it already, and it would be a very wise investment. You think about the incremental cost of what the reimbursement would be versus the human and economic benefits of that investment. Anybody on Wall Street would tell you that's a no-brainer, but yet we haven't done it. And policy leaders need to step up to the plate and make those changes.
So I can add a little bit. So I guess we have 2 action plans in the report. One is, in general, what we need to be doing as a group. And I think the state has already started a stakeholders group, which is really impressive. We hope to show that as a model to other states also, and let's see if we can see some better outcomes down the road from that. I would also add that there are already lots of champions on the ground. And everybody, literally everybody in the interviews want to help, and they want to they want to bring about change. And they want to collaborate. I guess the question the part where everybody's still struggling is, how do we coordinate this? And that's not an easy task. And you have collaboration across the state, You have the collaboration across the community. You have collaboration across providers and professionals that traditionally were not part of the maternal health care group. And so that's not an easy transition. And so I think we need to start thinking very seriously, okay, if we really want to address the crisis and we want to address the preventive part so that the crisis does not continue, it's first good to have a good mapping of what's going on. And then also we need to assign coordinators, because we always assume coordinators are going to come from the sky. And that's just not the case. It takes a lot of work. People that are already doing things in the community are already overwhelmed with things that they are doing, because we have certain people in communities that are always signing up to do the things that require coordination, and those sometimes are not always rewarded. And so we need to start thinking about how do we reward those coordinators also.
One area that I would like to highlight and add is one of the findings of our study was the importance of health literacy and education and awareness about the whole maternal health. And for example, we found out that mothers who have higher education, better health literacy, are more likely to receive a specialized care if they need from out-of-county resources, which provides us with this proof of principle to how important health literacy and education and awareness about healthcare is in terms of maternal care.
So another way to view this is, my suggestion was to address some of the short-run challenges. Those are things we could do today. What Amir is suggesting are the long-run solutions to this problem. And we need to do both. We can walk and chew gum at the same time in this country. And I find it unconscionable we haven't made more progress.
Yeah. And I just want to add quickly that Heartland Forward is also facilitating, and we helped form the Heartland Health Caucus, which is a group of legislators, representatives from the governor's office, and also the health departments across 6 states, including Arkansas. So Arkansas, Oklahoma, Kansas, Missouri, Kentucky, and Tennessee. So one of the priorities of the Health Caucus is maternal health. So we hope that this report can also bring about some policy changes through that group.
Yes, absolutely. And I know that Health Caucus and other areas, the focus on community health workers can often help bridge the long-term goal of higher education and the short-term need for access to services. So appreciate the focus on that. Before we close, I do want to see if there are any questions from the audience. I assume our AV team can help with some mics. I know staff there. Oh, I see you there with some mics. Okay, thank you. So we have a mic here. So here in the front we have.
Hi, thank you so much for giving this amazing talk. My name's Sonali. I work at Google Health, and I really appreciated the solutions that you provided and some direction. And I had some questions around, you touched around like mental health services awareness and also around telemedicine. And I was curious, in your visualizations, you talked about how mental health, things like postpartum depression, other issues are severely impacting, for example, women of color or Black women going through pregnancy. And so is there an awareness around access to therapists with telemedicine amongst women, specifically Black women who are pregnant, and not just therapists, but specifically like culturally salient resources? Just curious in terms of the role of technology, but also maybe not even technology.
I can go. I'm so glad you asked that question, because the mental health screening came up a lot in the interviews, and I think it's very important. Telemedicine definitely can play a role in offering access, not just to therapists, but in other forms. There are also platforms available for mental health today. The problem is that we have so many, and not all of them are evidence-based that we know are working. And we actually were discussing this with Dr. Greenfield a couple of days ago. Having the screenings is a first step, and it's not enough. And actually, if you just do the screenings and you don't know where to send this woman, that's actually worse than just not having the screening, because then they're frustrated with, why did you do the screening if you don't know where to send me? There are innovative ways of thinking about mental health. I think one of the things that I'm hearing often in many conversations on mental health is that we're assuming everybody needs a therapist. And that means that everybody needs to have a pathology or what issue you have. And anxiety or other stuff that many of us face every day, they need to be addressed, but not necessarily through a therapist. Like there's a study in Australia that shows that sometimes physical exercise, particularly outdoors, can be more effective for some, depending on your type of anxiety or depression, than, say, a therapist. So we need to be looking at the evidence-based methods, and we need to switch the mindset from therapists as well. And I don't have a clear answer on what the forms that would be, but there are platforms, and there are, one of the things we were looking at is CETA Global, is an organization that emerged from Johns Hopkins that offers one solution. I'm not saying a solution, but there are others out there that we should be looking at and see what works for our state.
Thank you. Thank you so much. Other questions from the audience? I see one over there with Nicole.
Hi, first, thank you. Thank you for this presentation. My name is Margarita Solorzano, and I feel there's a lot of echo. But I was wondering if the economic part, the impact, are you also considering the family impact? Because you mentioned, especially when there is more than one child already, and there is complications in the family, it is not just the mother and father, it is the whole family that needs to pitch in to support the pregnant women and also take care of children. And all the other issues that you already mentioned. And my other part of the question was mental health and the extension of Medicaid after birth, because we know that most of the deaths happen after birth, a year within the birth.
No, those are excellent questions. I've done a lot of work looking at the cost of caregivers and on families as it relates to chronic disease. It's no different than looking at maternal health. If anything, I would emphasize that our cost estimates in terms of the economy would be conservative, because family members, a husband, even an older child may have to miss work if they have to fill in for the mother. And so there are huge caregiver costs, and those are never really calculated into the medical equation nor the economy. And they should be. They are substantial. I think one other kind of maybe point B that could be done around how do we fix the problem or address the problem more appropriately today is around extending postpartum coverage beyond 60 days, at least up to a year. There's certainly studies showing that can make a significant difference in maternal health outcomes, as well as on the infant, and allow mothers to get back into the labor force and not feel that they are being ostracized. So very important points.
Thank you. I think we have time for one more question.
Thank you so much. This is a very important topic. I've been a caregiver for 14 years, and I relate directly to this. My name's Katie. I'm a PhD candidate at Gonzaga University, and I've studied the role of maternal infant access, particularly from the patient partner perspective. My question, the Policy Center for Maternal Mental Health recently did a presentation, and they were referring to coupling care, so pediatric care for children alongside maternal mental health or maternity care. Has that been part of this conversation in reducing caregiver burden?
It definitely came up in the in the interviews a lot. And anything that we can do as a one-stop shop for those moms is definitely going to help. Particularly, again, when we go back to transportation, childcare, parental leave, and all these other things that are missing components that we still don't have aligned. Yes. Amir, I don't know if you want to add to that.
Thank you. Ross, Maria, Amir, this was absolutely wonderful. I know many of us in the room appropriately focus on the patient and the kind of the heart-wrenching stories that we know. The economic lens was intriguing when I saw the title of the report, and also I think critically important, particularly as we work to shift policy and practice and take action. So Thank you so very much for your time, for your dedication, and for your partnership and leadership throughout the coming years. Please help me thank Heartland Forward.